Venugopal, President of CSI, Vimurthy, who is here all from USA, and the session is of great relevance. Venu, you want to say something about the echo in Ecmo, or should we start the session straight away? Venu says, let's start the session. It's a keynote address by none other than Poonam, who will give a brief and a vast experience of using echo in the practical sense in cardiology. Poonam.
Thank you, Chairpersons. Dr. H.K. Chopra, it's really a privilege to be here with you in this August gathering of cardiologists. I am a physician, but I went on to specialize in cardiac anesthesia. And it's a big thank you to my alma mater, All India Institute of Medical Sciences, where I come from, and I've been working for 17 years. And in that process, met stalwarts like Dr. Nanda and Dr. Chopra here. AIMS does something to the tune of 5 to 6 Venoarterial Ecmos on its cardiac surgical patients every week. And we are lucky we do everything on Ecmo for them, which includes Echo for Ecmo. Without wasting much time, I go on to my first slide. We all know that Ecmo is the therapy for the failing heart, the therapy for respiratory failure, which is not absolutely resistant to other modes of therapy. And veno-venous as well as veno-arterial Ecmo is the thing that is to be done today. Probably every ICU, whether it is a pediatric or an obstetric or an orthopedic ICU, would soon be equipped with this very non-invasive therapy, which just requires a few invasive lines. So a centrifugal pump, along with a lot of tubings, an oxygenator, a bath warmer or a cooler, is what is required besides the expertise of the surgeon, the anesthesiologist, the cardiologist, as well as the perfusionist to perform this great act of veno-arterial Ecmo. Now, veno-venous comes in when we have to have oxygenation given to non-compliant lungs, and removal of carbon dioxide becomes an essentiality, as in ARDS, whereas veno-arterial Ecmo is required chiefly for cardiac causes. This is the circuitry for the veno-arterial Ecmo. The difference between the two is just in the site of cannulation. Veno-venous means maybe the draining site is a vein like the femoral vein or the internal jugular vein, and that is also the accessing site from where, after oxygenation in the pump, the vein is getting the oxygenated blood back. Whereas in veno-arterial, which has better results but less frequently done, the access pathway, that is the returning pathway, is always an artery. So when we are on such a modus, the veno-arterial Ecmo circuit would be my chief, where I would be talking about in this talk today. Heparin is the drug to be given, and it is this heparin which causes a lot of bleeding. The gas exchange through a synthetic membrane historically was first carried out by Dr. William Johann Kolff, and it was, however, Dr. Barlett who, on an ASD patient who had meconium aspiration of a neonate, saved the baby when he performed the first Ecmo on this child when his PO2 dipped very low. And while Bartlett was doing this Ecmo in the entire fraternity became the thing to do, but there was a setback for 10 years because the mortality was high. Echocardiography, as we know, is the thing to be declaring a patient's outcomes in the ICU or in the OR or in the CCU, and also today in the emergency medicine. So Echo for Ecmo is a very new technique, very little literature on it, and whatever little there is on my small experience from AIMS. So Echo helps an Ecmo patient by deciding whether this patient is fit for an Ecmo or not. Most oftenly, an Ecmo fails because we put it in an unfit patient. Monitoring this patient during support of Ecmo is the role of Echo. Insertion and correct placements of the cannulas is essential. Detecting complications of Ecmo is essential through Ecmo. And also Echo decides how to wean off the patient from Ecmo. So for patient selection, there are a few patients on which we do not perform an Ecmo. For example, a patient with acute dissection, which you can see in this patient in the upper esophageal aortic arch view. You can see AR, any severe AR, any AS, any aortic dissection is a big contraindication to putting in a central or a venous ECMO. Similarly, the presence of VV ECMO, if you have severe pulmonary artery hypertension, as you see in a mitral valve disease which is advanced, or in a tricuspid valve disease, and this patient goes into cardiac failure, do not consider a VV ECMO, but consider a VA ECMO. After this, the next important thing to consider is the presence of certain artifacts or certain things in the interarterial septum. Like when we are doing a venous ECMO, this view, the bicaval view, is the most important view to detect what? To detect the interarterial septum. The presence of any defect in the LA or the RA or a Chiari network at the junction of the RA-SVC junction rules out, precludes the use of an ECMO. So a pre-op echo is important to rule out the patient selection. So right heart anomalies like atrial septal defect, interatrial septal aneurysm, presence of a PFO, a prominent Chiari network, and a pacemaker on any ICD leads in the patients are all contraindications not to put the baby or the patient on ECMO. So these should be ruled out. And what also should be ruled out in this patient is an interatrial septal aneurysm, which though rare, is also very, very often found. If you do a transthoracic, just put a subxiphoid probe on this patient and rule out the presence of a aneurysm. Venous access cannula through the right common femoral vein into the RA is where the return cannula is. What determines the maintenance or the process of ECMO is the way the cannulas are placed. There are two cannulas, one venous or the return cannula and one draining cannula which gets back the oxygenated blood from the pump, and that is the access cannula. So if these two return and access cannula are held very close to each other, the process of recirculation sets in, and recirculation is a dreaded complication of ECMO. Why? Because it decreases the return to the heart and causes a low cardiac output. So the maintenance of ECMO is maintained by the position of these cannulae. Preferably the return cannula should always be placed proximal to the access cannula. And we will just discuss where the return and the access cannula should be. So for the insertion and correct placements of the cannula, 3D echo is very good because on 3D echo, the echogenicity of the cannulae is well seen. The guide wire, once it's put in, most of the ECMO cannula guide wires are echogenic. So they're very beautifully seen. And the moment the surgeon or the anesthetist is putting in the catheter over the guide wire, that's the process where thrombosis sets in very fast. So that speed is what the echocardiographer, the cardiologist, tells the intensivist as to how the casting or the thrombus formation is to be avoided. Echo complication cannula malpositions are very common during ECMO. They may happen in the presence of the cannula may go past the interatrial septum, the cannula may go and lodge into the coronary sinus, it may go across the tricuspid valve, giving rise to a lot of right ventricular dysfunction. It can go across the PFO into the LV, and once you are doing all this, what happens to the patient is actually the presence of a decreased drainage, decreased cardiac output, and ECMO failure. So mid-esophageal bicaval view is the view for deciding as to what is the most excellent place for the cannulae position. The interatrial septum, the tricuspid valve on the proximal heart, the SVC, the IVC are all very beautifully seen in this bicaval view, and this is the view for putting in the cannulae positions by the echocardiographer. Also, if you turn the cannula, the echo probe to the right, you can see the coronary sinus and you can detect the position of a catheter in the coronary sinus, which if present should be withdrawn because the ECMO would not continue. So a coronary sinus view and echo is very important along with the bicaval view. Along with this view, another view that takes very much importance, these are simulation views. We've just had a simulation in Viva in which the PFO is very nicely seen. So to see the PFO, the bicaval view comes in, and you see the PFO and see the cannula dislodgement from the LA into the LV, and you can rule out the cannula malposition. So this is where the proximity of the access and the return cannulae should be. The insertion and correct placement of the cannulae, the venous cannula should always be placed slightly distal to the proximal cannula, which is generally the arterial cannula on which the deoxygenated blood is coming back, so that the level of the aorta always remains above the level of the vena cava. So the echo can be seen very beautifully in mid-esophageal four-chamber views. It can be seen in the upper esophageal aortic arch view. It can be seen in the descending thoracic aorta, because when we are seeing flow in the aorta, the descending thoracic aorta view, which is always also seen very nicely on the longitudinal plane axis view by the echocardiogram on transthoracic echo, can be ruled out. And echo is essential to check the position of the cannula, as I said, to avoid recirculation, to avoid inadequate blood flow, and to avoid myocardial injury. Now, echocardiographic monitoring, as I said, monitoring during ECMO is also importantly done by echo. Monitoring could be done by seeing the flow in a mid-esophageal four-chamber view of the development of a new MR or a TR. The moment a TR is seen, it means there is pulmonary artery hypertension developing. The moment you see the severity of MR worsen, there may be LV distension and dilatation, and ischemia may set in, and that's the position where maybe an IABP would help more than the ongoing ECMO, and inotropes and vasodilators may have to be changed. So while we are doing ECMO, it is important to do echo to decide upon LV unloading. So this adequate LV unloading is essential to see in any kind, especially when you have, as in this case, the LV thrombus forming. Stagnation of blood in the LA-LV means there is decreased blood flow, and decreased blood flow coming from the lungs back into the systemic circulation means a decreased cardiac output, and that's the place where cannula position and monitoring of ECMO has to be turned into. Now, a lot of work on echo is done on ventricular assist devices for heart failure patients and very little on ECMO. While we are on it, the chief important view that we decide on the patient through a transthoracic or a transesophageal is the lower hepatic view. The lower hepatic view brings into focus the inferior vena cava and the hepatic vein. The diameter of the inferior vena cava gives us an estimate about the RA and tells us about the preloading conditions and how the volume to the ECMO patient has to be maintained. And the hepatic vein and its entry into the IVC is also a good prognostic marker about the continuation of the ECMO. The other very important thing is to do a pulse wave Doppler during a Venoarterial ECMO particularly. If you see any diastolic dysfunction happening, then the SD ratio on the pulse wave Doppler is a good view about telling us about the worsening from the pseudonormal to the restrictive pattern of the diastolic function. Complications on ECMO are very beautifully seen on echo, and these complications are chiefly because of heparin, bleeding, which may give rise to intracranial bleeds, and the patient may die suddenly or may go into DIC. The other very important dreaded thrombus, as I spoke about earlier, is the development of the thrombus, particularly along the cannula sites, even during its insertion. Now, this is very nicely monitored by the echocardiographer, and 3D echo has come into view. From the intraventricular thrombosis, which is a known complication of MI, a peripheral ECMO and LV akinesis increase the risk of thrombosis. So any akinesis, any thrombus migrating from one chamber of the heart to the other can be very nicely looked into. Particularly the LA appendage and the LV is the site where the thrombus has to be taken care of. The other part which is very important to be taken care of as a complication is the development, besides bleeding and thrombosis, and in a prosthetic valve, you can see the on 3D echo or an LVAD, the thrombosis develop very well. And you know that now the ECMO is not doing well. Venous flow obstruction, as I said earlier, the flow through the descending thoracic aorta and the ascending thoracic aorta is the hallmark for the adequacy of ECMO. And a very beautiful paper by Hanis Ray et al. Suggested that the development of superior vena obstruction and inferior vena cava obstruction is detrimental to the outcomes of ECMO. And SVC obstruction, by knowing the flow through the descending thoracic aorta on echo, is a good prognostic marker to prevent and see SVC or IVC obstruction happening. The development of cardiac tamponade, very common in all cardiac surgical patients in the ICU, but exceedingly common in the ECMO patient. This tamponade is easily picked up by a rise in the RA, the development of a pericardial effusion, and on echo, the development of any thrombosis or any clot into the RA, which may migrate into the RV. So pericardial effusion is a dead complication. I'm just finishing. The tamponades may happen inside the prosthetic valve. A venous cast may form around the cannula, which should be detected early. And patient on VA ECMO may develop a diastolic MR, which worsens the LV dilatation and the distension. And any distension is very beautifully then taken care of by there and then putting in a balloon atrial septostomy, which can be done on the bedside in most cases in our ICU. And this VA ECMO on echo would decide upon this. The RV dysfunction, if it is present at the time of initiation of the ECMO, may worsen, and this worsening is very nicely seen on echo, on serial echoes on this patient. And if you have a suboptimal TE imaging in a patient on ECMO, this TE imaging can be done better by putting in a Definity contrast. And this Definity contrast brings about the presence of a thrombus in the LV. So those are some of the very important features. We do a lot of integrated ECMO at our center, wherein to save time and to salvage the patient, we put the ECMO probes and cannulas at the time of going on bypass, especially for our TGA patients with intact ventricular septum beyond 3 months, or in our Al-Kappa patients, and also some of our TA-PVC patients. So we don't lose time. Early initiation of ECMO can prevent myocardial damage. And with the use of integrated ECMO, a surgical asepsis is maintained, so it maintains better outcomes. The procedure is very cost effective. You don't have to have dual cannulas of bypass as well as ECMO. And increased survival of up to 65 to 70% has been seen in our 10-year publications on the same. So integrated ECMO, you can have some tubing complications which are mechanical. They can be very nicely detected on ECMO, on echo. And any large hematoma around the cannulas or any bleeding is there. So for clinical judgment and hemodynamic parameters, echo variables also help us wean and decide whether ECMO is there as a bridge to transplant, and what are the parameters that we look for. An increase in the ejection fraction beyond 40%, the LV-ED diameter, if it lessens to less than 55 millimeters, the aortic velocity time integral is a very important factor. It should be more than 10. The most important thing is the opening of the aortic valve. At all times, if the echocardiographer keeps seeing the opening of the aortic valve, that it is opening nicely on the transesophageal, mid-esophageal long axis view at 120 degrees and doing a nice namaste with the right and the non-coronary cusps of the aortic valve, it means the ECMO is doing well. And of course, absence of any LV dilatation. So weaning and recovery on echo is well seen. There are conventional echo recovery parameters which depend on loading conditions. Strain imaging and tissue Doppler imaging are coming up in a big way for dealing with ECLS weaning. And next few publications in the next few years would be on how to use tissue Doppler and strain rate for weaning the patient off ECMO. And image intensifiers in cath lab help us put in good wires and cannulas. So fluoroscopy is good in hybrid suites which are now available. And I conclude by saying that echo is actually a teamwork. And if it is a teamwork, anesthesiologist, a cardiologist, a surgeon, and a perfusionist with the intensivist in the ICU are all for it, and that only successfully gives us the outcomes. I thank you all for your patient listening, and I thank once again the organizers for giving me time. Thank you.
Thank you, Dr. Malhotra, for making a complex subject look very simplified. ECMO is now gaining popularity in many of the centers in India, especially in critical care. And this knowledge of echocardiography would certainly be a very, very great boon, especially in dealing with critical care situations. Any questions from, any comments from the panelists?
No comments, but compliments. There is absolutely no question about the the role of echocardiogram in enhancing the outcome while carefully selecting the patients for ECMO. And there is enough evidence-based knowledge globally. And Dr. Malhotra, your presentation today has strongly supported. Thank you.
I just want to know how much it costs to the patient in a private hospital if we start.
Oh, yes. If you're doing a veno-venous ECMO for any corporate center, it's about 3 to 4 lakhs a day maintenance. We at AIMS are doing so much because we are subsidized by the government of India. And to us, the patient pays for a Venoarterial only 1 lakh, and for a veno-venous, the new one with the Mecche percutaneous or the Midos percutaneous leads coming in, something to the tune of 85,000 only for the cannulas. So we are very cheap at AIMS, but we are lucky because of government subsidy. But on an annual, a 3-day ECMO for maybe something like myocarditis at, let's say, any corporate hospital in the country would raise a bill of 20 to 25 lakhs for the patient. It's a very expensive deal. But the newer ones coming up, which have the advanced centrifugal pumps, we no longer use the roller pumps. The centrifugal pumps are very good. The oxygenators are great. And you're using heparin-bonded circuits. So with all that new things coming in, cost is going to come.
What is the advantage or intra-aortic balloon?
Intra-aortic balloon pump is enhancing or augmenting your diastolic function. This is taking care of both your systolic as well as diastolic function.
Thank you. Thank you very much, Professor Malhotra. May I request Professor Venugopal, President CSI, to kindly present memento to Professor Malhotra. Ladies and gentlemen, Professor Malhotra has recently begun a couple of years ago the World Simulation Society, of which she is the organizing secretary.